That's fine. So let us start by Alhamdulillah wa salatu wa salam ala Rasulillah, and let us pray Al-Fatiha. Muhammad. Can you see the screen?
Yes, we can see it, Doctor.
Yes, Doctor.
See? Okay. So today we are going to speak about the patient with diarrhea and dehydration. Okay. Sometimes you feel that is something which is simple, but really it is very, very important. If you know that it is considered one of the major causes of death in childhood is diarrhea. Okay, and we'll speak about that. Just to remembering you by a few slides about your clinical skills. Okay, your future as a doctor is a clinician, and to be a good clinician, you must able to get a lot of clinical skills which make you more professional. Okay, so now we are going to work with us more than 1,000 a day. If you concentrate in this advice from my side, I think inshallah 1,000% you will be a good clinician. Okay, your value is in your clinical sense. So always try to focus in the disease and the patient feelings, which is very important. Number two, if you are going any interview or history taking with a patient or a family, you must be friendly. Okay, no interruption. You must be sympathize with the family, consider their feeling, which is very important. Okay, eye-to-eye contact with the patient, listening carefully to them, give them attention, and sometimes you need to observe their reaction. Sometimes the family is crying because you are giving the diagnosis or speaking about something painful to them, and you are still speaking. You must have at the end a logic flow of the content, either the meeting or the family or the examining of the child. Okay, try to focus in this place. The issue of history taking, it must be an art. Okay, the second point, you must have a good introduction, as if you are asking open questions to let the patient speak. Sometimes you need direct question if you need to ask about certain point. So you must be able to ask many questions, okay, which uncover the hidden things through the family. For history, please, we don't have any excuse to miss any part of the history, because every part will guide you. What is the diagnosis and the differential diagnosis? In many situations, it looks confused. Oh, I don't know, is it Kawasaki? Is it a measles? Is it a viral rash? Is it bacterial infection? Like that. So if you are not going through the history as you are preparing, inshallah, we will see your presentation of long cases. What about the prenatal? You must start even prenatal, and then natal and postnatal. You must get idea about the feeding about the growth and the development, about the immunization, what about the previous illnesses, about the function, and about the family and the social history is very, very important. And any family history of disease, any consanguinity, any what is about the family dynamic, who is staying household, he is in contact with anyone, what about the social things, especially if patient has asthma or like that, and you need to attend many social and good exposure. Is there any psychological disturbance? Is there any substance abuse? Is any stability or instability in the family which can affect? For all this is your job, and it must be clear while you are interviewing any patient, please. Okay. Something which happen that we are trying to reassure the family by false hoping. Don't do that, please. If you found the family are anxious and afraid of a diagnosis which you are suspecting, don't say, don't worry, it will not be okay like that. No, you must be honest and put this one in your mind. We must be honest and clear and frank. It is not bad, but you must be sympathize. As if now you are going to speak to this patient today. Oh, ma'am, your child really has a gastroenteritis, which is a common disease in the childhood, but he has severe dehydration. He needs to be admitted to the hospital. He needs IV fluids. He needs some investigations. He may need some another medication. Otherwise, he will be in danger. But if you tell them, don't worry, it is a simple thing, but we need to admit to the hospital. So they are confusing. The simple thing is why you are admitting. So they are thinking that it is optional thing. So sorry, doctor, try to write for us treatment. But if you are clear, this is a gastroenteritis with severe dehydration, with poor oral intake, and the decision is to admit the child. If you admit him, hopefully the result will be very good and he can be discharged as soon as we can. So don't give the family a false or unclear hope. Am I clear for that? Can you hear me or not?
Yes.
Yes, doctor.
Yes,
Yeah.
doctor. We can hear you.
Please, I need you to concentrate in every word I'm speaking about, because this is your future practice. Okay? You must be honest and clear, but sympathize. Because in your job, you are dealing with all varieties of disease, with infection, with malignancy, with autoimmune disease, with unknown pyrexia of unknown origin, with a lot of cases. You cannot guarantee for anyone the result, but also you must be tough, you must be sympathized. So you must tell them the situation by honest and clear, but please consider the one in front of you. If he is the eldest one, he is your father. If he is youngest one, he is your child. If he is in the same, he is your brother, and speak to him by the same manner. That is the thing which Allah said to the Prophet sallallahu alaihi wasallam, وَمَا أَرْسَلْنَاكَ إِلَّا رَحْمَةً لِلْعَالَمِينَ. You must be rahim, means sympathize with everyone. It is better while you are still young to try to remember the name and the gender of the child you are examining. Okay. Of course, your dress and speech in front of the patient is very important. The manner you are dressing, you are speaking, you are presenting yourself. The most important also, you must have the art of differential diagnosis. I mean by differential diagnosis, always you put the working diagnosis of yourself, but you must consider the differential diagnosis, because many times it will come to you the one of the differential, not the original one, especially after investigations. And even in the same disease, you need to get differential diagnosis. I mean, a very famous example is the nephrotic syndrome. Nephrotic syndrome itself can be just a primary nephrotic syndrome, steroid sensitive, but it can be secondary nephrotic syndrome. It can be steroid resistant. It can be frequent relapsing. It can be like that. So you must be able to specify the details of the diagnosis. You may ask someone, what is the diagnosis? He will tell me asthma. Alhamdulillah, he is even not keen to say it is bronchial asthma. It is ovid asthma or whatever. No one knows. So is it bronchial asthma? Is it intermittent or persistent? I must be able to specify the diagnosis. So in every diagnosis, don't accept it easily. Even the most common diagnosis, this is AGE. I came to the conclusion that this is AGE, bacterial or viral AGE with moderate dehydration, like that. So everything can be more clear, more professional for the one. Of course, breaking news, especially breaking bad news, is part of your job in the future. After 1,000 a day, you will start to tackle that. You are the one who must be sympathize and honest and clear and ask for a conference with the family and try to tell them, so sorry, I need to inform you the result of your child who got that or this disease. Okay. Don't forget that we need equipments for examination. This is not new for you, but you must keep it always with you. Okay? For every situation, you must be ready. And please don't forget to go through this safety pin. Means if you are going to examine the nervous system for sensation, or you are going to do the Beniski, it is unhuman to use your nail, which may be not sterile. It is not acceptable to use your pen or the drum like that. No, you must have special equipment for every situation. Of course, from the early steps, you must bring the developmental assessment kit and the tools. It is very important. Okay. It is here, you can just go through it, and you may also need to add because some other optional consider very important. How to be more professionalism? Okay, number one, you must have elegant appearance. Okay, Allah subhanahu wa ta'ala prefer for his believer to be in a good manner of dressing. Your manner must be good and decent and sympathize. You must have kind attitude. Don't be aggressive in front of the patient. It is not good at all. Consider whatever the patient he consider weak at the moment he is coming to you. He is very afraid. He is thinking what happens. Some people can tolerate the disease for themselves, but they cannot tolerate it for their kids. So they are coming to you in very fragile situations. So you must be very kind. Highly responsibility. Your responsibility is to give benefit and don't give harm. Remember that even in Islam, you are not allowed to cause harm for anyone. You need to give benefit. The Prophet said, "La darar wala darar." You are not allowed to cause harm by any way. So you take care. Even if you sometimes we are not able to give anything. One patient with end stage disease, which we cannot do anything, we will say that we are going to give palliative because we don't have anything we can treat. But don't cause harm, please. Okay. Remember, always there is a morals for practice medicine. You must go through it. You'll find it with the MMC. Okay. Confidentiality is very important, but to be confident also is very important. But don't be overconfident because we are still learning until we are dying. And if you are very good knowledgeable, you will find someone who is more knowledgeable. So please, I need you to be confident, but don't be over. If you see the patient, the first one is to wash your hands. Okay? Between patients, you must do that. So washing of the hand is a part of the medical practice. I used it to tell them if you are doing washing hand for wudu, for salah, for Allah to accept us, it is the same. We are washing our hand not to infect people. I go for this patient and got the microbe and give to the other one. It may be the second one are immune deficient or he cannot tolerate or who got severe infection. So please, hand washing, consider it as obedient to Allah. Because anything proved by science, we must go through it. Okay. Try to make your patient comfortable with you, because the patient or the family will be in a bond with the doctor. They will consider, many of them said this is the family doctor. So try to have a good bond. Of course, exposure of the patient is very important, but don't attack the dignity of anyone, especially for the adolescents. Another important aspect for physical examination is the position. You must be to the right side of the patient. Using your right hand, you must have your sequential manner. Okay, you have proper exposure, and you need to expose the area which you are examining, and after that you need to cover it if needed, so you keep the dignity and the privacy of anyone. It doesn't mean that he is sick, that he has no dignity or privacy. Please take care about that. Okay. You must establish a good relationship between the patient and the doctor. Okay. First, for children, you must try to speak with them so they will not afraid. So we must consider for every age. The preschool, you can say, oh, hi, how are you? What's your name? Young age, no need to look at their eyes. If you look to the eyes of the infant, he will be afraid. So every age, you need some handling for the situation. Answer the patient questions about the situation of the baby. And if you don't come to the conclusion, said, we have blah, 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 we are doing some investigation to give you the complete answer. Okay. Of course, to be a good observer is very important. So observation is very important. If you saw any patient, you must ask yourself, he looks well or not, ill, dysmorphic, what about his nutrition? You must be able to answer for that from the first look. So please, I'm advising you, your clinical practice. Number one, you will introduce yourself to the family and get their permission, and washing your hands. Okay, and try to put the patient in the good position and the exposure as needed. And then you must come back one step back. Okay, and ask yourself, the patient looks well or ill or sick? He is normal or dysmorphic feature or a special baby? What about his nutrition? He is a good nutrition or underweight? Okay, he is alert or not? He is comfortable in bed or not? He appear to have any acute condition like respiratory distress or not? He looks a chronic or acute patient. He has any signs of dehydration or like that? Does the patient appears clean or not? It may be give some, sometimes you are dealing with child neglect or child abuse. So he looks well dressed, well cared or not. Okay. Is there any signs of irritability to the child? Okay. It is very, very important. Okay. Sometimes you need to even to see the surroundings. If the patient has like beside him, if the patient has cerebral palsy, you will find beside him some aids for him. If the patient has bronchial asthma, you will find nebulization. That's all will give you a guide about the situation of the patient. So please, your observation are very, very, very important. Okay. So we must do general survey and then check the mental status and make sure that the room is comfortable and with a good light. Observe for anything before touching the child and completely expose the body part you are inspecting while the patient in rest. So today we are going to try to apply all this by a simple manner in the gastroenteritis. Here you can see the causes of death among children. Okay, which is very important. You can see how much is it. In the neonatal period, here is the post-neonatal, where you can find now the gastroenteritis. I need you to be shared with me because I didn't prepare this remote during speaking from one side. You can see here, pneumonia is a very, very important, okay? Other group, there is a congenital diseases, there is injury, there is malaria. By decreasing, here is diarrhea, which is around 10% of the causes, but it is one of the causes of more morbidity and mortality. What is the diarrhea? Of course, it is increase in the fluidity, volume, and the frequency. Okay, acute diarrhea, and this is an important point, you must be able to say, is it acute or chronic for most of the diseases? Okay, acute diarrhea means less than 2 weeks. Chronic if more than 2 weeks, but it's different between disease. Also cough, it will be the same. If the patient has coughing for less than 2 weeks, it is acute cough. If it is more, it will be chronic cough. But to say arthritis, you need to say it is chronic arthritis, you need up to 6 months, 6 weeks. Let's say the definition of acute and chronic may different between different presentations. The types of diarrhea may be acute watery diarrhea, which the main bulk, it can be presented by dehydration and malnutrition. About 10% may be dysentery, okay, which become complicated by anorexia and weight loss and the damage of the mucosa. Persistent diarrhea, okay, also can cause dehydration and malnutrition. Diarrhea of infectious origin, it can be acute, okay, or prolonged, or persistent and chronic. So we are said, is it acute, prolonged up to 2 weeks? Usually this is a multiple causes. If persistent more than 2 weeks, we are going to say, is it chronic diarrhea, which have a different category of disease, especially inflammatory bowel disease and malabsorption and like that. Here you can see diarrhea also can be classified according to the cause. It can be infectious and non-infectious. Infection can be divided into 2 parts, either infection in the gastrointestinal tract itself, and we will call it enteral diarrhea. Enteral means in the intestine itself, okay? Most probably it is a viral, mainly entero, adeno, and rotavirus. But it can be bacteria, and there is some severe bacteria which can cause life-threatening condition like cholera, like Shigella, Escherichia coli, okay? Sometimes it can be parasitic infestation, like Entamoeba histolytica, Giardia lambelia, Candida infestation by parasites. So all this is enteral one. So what is the issue of parenteral diarrhea? Parenteral diarrhea, it means the patient has diarrhea or gastroenteritis as a part of systemic disease. The most Famous example is the dengue fever here. If you got patient with dengue fever, also as we speak before, we need to give a full diagnosis. So the full diagnosis, it was either simple dengue or complicated dengue, which can be dengue with more warning sign, or septic shock dengue, or hemorrhagic dengue. So if we said, what is the dengue with warning sign? We will find the warning sign is the abdominal pain and the vomiting and the diarrhea. That's why this gastroenteritis is a part of dengue fever. Sometimes it will come with the otitis media in the children. Remember that otitis media and the pneumonia and UTI, all this can be presented like AGE. So you must check all these organs. You must comment if the patient has acute otitis media, has any pneumonia, because lower lobar pneumonia can irritate the gastrointestinal tract and start vomiting and lose motion if he is swallowing the sputum like that. So now the causes of diarrhea can be, who can answer?
Bacteria, Salmonella.
Bacteria, not the bacteria is not the most common cause. The most common cause is viral. Okay, so it can be as it is in front of you. Just read this. That one can be infectious or non-infectious. Infectious can be, who can continue, please?
Enteral or parenteral.
Good. Parenteral can be either.
Otitis media, pneumonia, UTI.
Okay, this is the parenteral, very important. Non-infection can be malabsorption. And the malabsorption is a very, very important part, especially for the gastroenterology subspecialty, lactose intolerance, cow milk protein allergy. All this must be considered because it will give prolonged or chronic diarrhea. So how can we approach to the diarrhea? It is the same for any disease. History, physical examination, investigation, and at the end I need to treat. I need you to remember that about 70% of the knowledge or 75% will come from the history. So you must be a good history taking, please. Physical examination will help you about 20%, and the remaining small amount, 5 or slightly more, will help you is the investigation. If you are inverting the pyramid and make yourself the doctor of blanket investigation, I mean anyone come to me, hi, please go to the lab and do 1, 2, 3, 4, 5, 6, 7 until I can count, it is not good, because you are going to lose your clinical sense. History, then physical examination, then investigation, and each one has its own part. Okay, this one is done to come to the diagnosis and then to the treatment, which is the same one which are going to examine you from now and forever, even if you are going for MD or like that. History, and then physical examination, and what investigation is coming. So what is the diagnosis and the differential diagnosis, and then what is the treatment needed. So history, you can read that the chief complaint, when it started, for how long, to define is it acute or chronic, how is the frequency and the volume, what is the nature of that attack, is it if secretory diarrhea, and it is very important part. Another classification of diarrhea, we speak about the causative, we speak about acute or chronic, we speak about now, is it secretory or osmotic? Secretory diarrhea, it means it will be resistant even the patient is fasting. I make the patient NBM and start IV fluid, but he still having diarrhea. It means that he has secretory diarrhea. Osmotic diarrhea, stop with fasting. Dysentery, I will find the triad for dysentery, which is mucus, blood, and pus. Okay, and sometimes, many times, we have tenesmus, which is straining during voiding. Steatorrhea, which is a part of the malabsorption, you will find the stool looks pale and greasy, contain a lot of fats, globules, bulky, and poorly formed, and sometimes poorly odor. So from asking the nature, even you are able to say, onset, is it acute or chronic? Frequency and volume, you are going to know about the nature. Is it secretory, which is very, very dangerous? Okay, cholera, like that. Is it osmotic? Is it dysentery? Is it steatorrhea? And sorry, examination of the diaper of the patient sometimes will guide you. Don't be shy, or don't be picky to get a look during the examination, especially of small babies. Because sometimes the mother speak about diarrhea, and when opened, we find a red jelly blood. What can be the diagnosis?
Dysentery.
Can be dysentery, but what is the most common if he is infant, 5 or 6 months? Very famous surgical condition. What is the most famous condition? A small baby presented with you with red currant jelly diarrhea. Intussusception. What is intussusception? A part of the small intestine are invaginated in itself. So it will cause this manifestation. Sometimes the mother will ask, did you notice that? Yeah, it was very small amount, doctor, and I think it may be, I give him some food, which like that. So it is very important to even try to check the characteristic of stool yourself if it is available. Okay, especially in critical cases or the patient look very sick. Of course, you must be able to ask about the frequency, the volume, the consistency, the color, the blood, the odor, and the mucus. Bristol stool chart is very important to define how is the severity of the diarrhea from Bristol 1 to Bristol 7. Okay, I think all of you must know these details. Then we are continue about what is the complication you must suspect, and this is a very important for any disease. For any disease, you are getting the history. You have like any tree, you have root and fruit. I mean the root, is there any cause? And the fruit, which is the complication. So this diarrhea may be because the baby are small, he was not given rotavirus vaccine, and he has no other malabsorption or fever or like that. I may consider him rotavirus AGE until proved otherwise. But what about the complication? The complication may be dehydration. And the signs of dehydration is very important, and take care that if you didn't diagnose the dehydration on time and manage it, you can cause a very big harm to the patients. We will speak about that. If you find the patient thirsty, irritable, restless, lethargic, and start to be consciousness not competent, no urine output, you must take care. It is the patient is going for the worst complication of dehydration, which is can be shock, can be renal failure. We'll speak about that. Okay. If the diarrhea are prolonged, especially if the patient from the start are weak and like that, he can get malnutrition. So you'll find the child started to lose weight, failure to strive, and the specific symptoms according to the disease, and then he will be weak and can catch another infection. He just finish the EGE, then he will progress to pneumonia like that because his defense is not good. Okay, other, okay, like any electrolyte disturbance or any anemia or like that as a complication. So we must ask about the past medical history. Was given any medication? It is very important. You know that some of our medication can give us a clue, like amoxicillin clavulanic acid, like this augmentin, can cause diarrhea if given to the child, and you must be able to counsel for that. Some antibiotics also can cause the same diarrhea. Some antibiotic can cause the red urine, like rifampicin, the treatment of TB. So you must, when you come to write any medication, you must know what you should to teach the family during prescribing that one. Okay. Any history of medication, of antibiotic, or even operation for the gut. What about the diet? Okay. Did the mother introduce any new type of milk? Is there any family history of food allergy? Okay. Similar presentation in the family also, like inflammatory bowel disease. Inflammatory bowel disease is a chronic disease, is a chronic inflammation of the bowel with two types, Crohn's and ulcerative colitis, with a lot of manifestation for the gut and the extra intestinal manifestation. Cystic fibrosis, of course, you will know it is a disease of malabsorption and the chronic diarrhea and the infection. Okay. Social, it is very important about where the child stay. What about the water supplementation? What about the sewage disposable? Educated family or not? Then if you come to the physical examination, you are going to check, number one, as we speak generally, if the patient is conscious or unconscious, is irritable, he looks very lethargic and weak, he looks pale or jaundice, he has any other apparent thing like lymph nodes, malnutrition, signs of anemia, and check his anthropometric, okay, to say he is, and plot him in centile chart is very important. Any child, you must be able to say he looks appropriate for age or less or more, and I would like to plot him in the centile chart. Hydration status, we'll see the table, and then go for the abdominal examination. Any examination must be systematized. It means you must start by inspection, palpation, auscultation, and percussion. Okay. For the first look, if you see the abdomen with a patient with severe diarrhea, it may be you are able even to see the peristaltic movement. Is there any previous scar? Is there any abdominal distension? Is very important. And when you are going for palpation, you must check, is there any tenderness? Is there any rigidity? Is there any mass? What about the bowel sound for auscultation? You must know that the bowel sound is up to 5. It is not so high like the heart rate. If you find it very, very frequent, it means there is increased motility of the intestine. Okay. Sometimes you need to check the perineal area. If there is any excretion, it will give you a clue for the severity of the diarrhea, and it may need treatment just not to be infected. Is there any infestation? Is there any blood? It is very important. For the dehydration, which is one of the causes of death in diarrhea, is the dehydration. How to check? We have a lot of parameters. Okay. Is it number one is the weight. I mean, if the patient less than 3 to 4% it is mild, from 5 to 10 it is moderate, and for severe, more than 10 it will be severe dehydration. This is for small children. If slightly eldest, we can put the issue of 347. Okay, you must speak about the weight loss, the general appearance. I mean, he is alert and well, or restless, or he is drowsy. What about the anterior fontanelle? Because most of you are missing that one, which is very important. Is it normal or sunken or very sunken? What about the eyes? Is it normal or sunken or grossly sunken? And does the baby cry without tear? Which is also an important sign of dehydration. If there is crying and no tears coming. What about thirsty? Okay, if no, it is mild. If thirsty, it is moderate. If refuse to feed completely, it is not. It means that he is in severe situation. Mucous membrane of the mouth and the other, is it moist or dry or very dry? And if you leave the baby at that level, you must check the vital sign. And remember that the vital sign, its name is vital sign. It means it is vital. You are not allowed to miss it, because you cannot judge the situation of the patient without this vital sign. The vital signs for us is the pulse and the respiration and the blood pressure and temperature and pulse oximeter. So you just make it adding a pulse oximeter to have this 5-1. So you must go through the vital sign, which is started to be affected. It is very dangerous. Let us ask, how many types of shock do you have?
4.
Which is?
Cardiogenic, hypovolemic,
Okay.
anaphylactic, and
Ischemic.
yeah,
Ischemic shock.
Ischemic. Is it 4 or 5? Okay. You need to review the table, but even any one of these shock are divided into 2 types, which is compensated or decompensated. So what is the difference between compensated shock and the decompensated shock? Who can answer? Whatever the cause, our situation, we have hypovolemic shock. So how can I say, is it compensated or decompensated?
Is it the compensated means that your body can still maintain the blood pressure?
Yes, very good. So we are going now to check the pulse and the blood pressure. If both of them, if the pulse are shooting up and the blood pressure are shooting down, so now you are getting for decompensated. Do you know what is the meaning of compensated and decompensated? For the survival, if the patient has decompensated shock, the probability to survive are very low. That's why if your patient came to you with severe gastroenteritis and dehydration, and you are not able to assess him by professional manner, and you left him, and he is started to be on decompensated or uncompensated shock, and he shifted to decompensated one, and then he either got severe renal failure or unreversible shock. Sometimes the decompensated known as unreversible shock. So either the patient die or he will continue with chronic renal disease. That's why our responsibility in medicine is very high in front of the patient and in front of the gods. Okay, of course, skin turgidity, you must do it for every patient if it is normal or slightly reduced or very reduced. Okay, and urine output, don't forget to ask about the urinary system, because if the patient came and the mother tell you it is for the last 12 hours he didn't pass urine at all. It is very dangerous. You need to give him rapid bolus to save the kidney, because the kidney, its role is to secrete urine more than 1 ml per kilo per hour, 1 to 2 ml per kilo per hour. If he stayed for 12 hours not working, it means his kidney may be in danger and he may end by chronic kidney injury. Okay. Okay, this is the criteria, the same, more or less. Okay, but try to put it together. Okay. The mental status, if you started to be affected, the heart rate, the breathing, the pulse, which I speak to you that this is the vital signs. Add with it the capillary refill and the perfusion and the blood pressure and the other system as we speak before. This picture will give you an important lesson how to examine for dehydration. I mean, we must have flow for examining any part of the body, and we must be systematized. And it is very simple. If you are going to start, you can start from head to toe. So there, what about the fontanelle? Is it sunken or very sunken? Okay. What about his consciousness level? Is normal or disturbed? What about the eye? Is it sunken or not? And what about the tears? He is crying without tears. What about the mucous membrane? It is dry or very dry. What about the chest? He became very tachypnic because persistent diarrhea will cause metabolic acidosis. What about the skin turgor? Is it increased or not? And then you are going to check the capillary refill time, the blood pressure, the tachycardia and hypoperfusion. Okay, all this is very important. And then a check for the urine output and the how loose the baby. So all this will guide you to the severity of dehydration and if the patient in shock or not, and if he is in shock, he is compensated or decompensated shock. After we examine the patient, we concentrate about the dehydration now because it is the most important. Many patients have chronic diarrhea as we speak to you, even if it is inflammatory bowel disease or irritable bowel disease. They are living between us normally. The only difference, they are visiting the toilet more than normal, but they can survive. But the issue if the patient have acute diarrhea, so he lose a lot of fluid and will go for dehydration. Dehydration is the killer of the child. Dehydration, as I told you now, it can danger the kidney and end by acute kidney injury, which can prolongate to chronic kidney injury, and it can end by decompensated shock, which the patient cannot survive. It can cause electrolyte disturbance because the patient already losing a lot of electrolyte with the diarrhea. If the mother used to give only air, water, so it will be disturbed the electrolyte, and at the end, many patients can end by DIC, disseminated intravascular coagulation. Okay, so now I try to detect the diarrhea. I try to detect the degree of dehydration and the emergency. So the investigation I need to do, try to remember that I prefer to divide the investigation into 4 groups. The number 1 is the lab result. Number 2 is the radiology if needed. Number 3 is the specific test for this condition. And the number 4 is, do we need to do bedside test or not? Okay, and of course there is a 5th one, which is the advanced investigation. Okay, if you apply this for any disease, it will be very clear. For the blood test here for diarrhea, in front of you, we need full blood count. Is it needed? Yes. Who can tell me the importance of full blood count in case of diarrhea?
the causative organism for causing diarrhea.
Which may be
Looking at the white blood cell count,
yes.
if it higher, so it cause the bacteria causative.
No, still can higher, but not bacteria. So what is the important inside the white count itself is the differential count. Leukocytosis means there is infection. But if it is lymphocytosis mainly, so I may think for viral. If it is neutrophils, I will think about bacteria like that, okay? Also hematocrit is very important. You will see if the patient with dengue fever, his hematocrit is approaching 40, it is one of the warning signs because it can cause abnormal coagulopathy and like that. Renal profile, is it important?
Yes.
Yes.
Why?
Because we need to know about the bicarb. And
To assess the dehydration.
Yes, blood urea and serum electrolytes may be disturbed. I mean the kidney function test itself. What is the most important electrolyte for us?
Homeostasis.
No, what is the most important electrolyte which you must check?
Sodium.
Sodium, very good. Why?
For the heart contraction.
No. Another class.
Osmotic pressure.
Yes, yes. We are dividing the diarrhea into 2 to 3 types according to the sodium. Either hypo or iso or hypernatremic. The most common is the iso, but hypo also can occur, and the severe hyponatremia can cause convulsion and even loss of consciousness. Hypernatremia also are very dangerous, but treatment also you must be very professional. Okay, so it is very important. You mustn't miss because renal views, which I mean blood urea serum electrolyte, are very, very important and one of specific of diarrhea. Okay, blood culture are very important and sensitivity, even blood gas. If you feel that the patient has bad perfusion and you feel he is in compensated shock, you must check for metabolic acidosis. Okay. Of course, specific also is the stool investigation. We need for microscopy, for any infection, for culture, okay. Also, if you need to examine for rotavirus or bacteria, it is very important. Stool pH is very important. It is the same idea, like you are checking for the urine. Stool pH, if you found the reducing substance, it may indicate some lactase intolerance. If you're thinking about malabsorption, you may need to collect the BO for 72 hours to see how much is the fat, because steatorrhea can be diagnosed by that. In cases of chronic diarrhea, we may need to do colonoscopy, especially if bloody, to rule out cystic, to rule out irritable inflammatory bowel disease, especially ulcerative colitis or Crohn's disease. We may need to add another investigation like urine if you suspect it is UTI, or we may need to add another like dengue if you suspect the patient is coming from dengue prone area with fogging like that. We must rule out that. Okay. So this table, you must go through it, please. It is very, very important in your practice. Remember that 75% are isotonic, but hypertonic can be up to 15%, and the hyponatremic or hypotonic one is up to 10%. Okay. The issue here is the sodium are changed. the importance, if you are treating all with the same management, it will be more worse if the patient has hypernatremia and you are adding more sodium. Okay, so that's why these electrolytes are very important. Remember that hyponatremia can be presented also by convulsion, which is very common. And remember that rapid correction of the hypernatremia can cause brain lysis. So be very meticulous and you ask your senior colleague for that. So if I saw any patient with gastroenteritis, I will ask myself, is it acute or chronic? What about hydration state, mild or moderate or severe? Can I define the etiology like viral, bacterial, dysentery, or other? Is there any other complication like acute kidney injury, like shock like that? Is any concomitant disease as a part of malnutrition or like that? What about affect growth and development or not? So this can be applied for any disease. Is it acute or chronic? What is the state of the patient, stable or not? What is the etiology? What is the complication? Is there any concomitant disease? Does it affect growth and development or not? Okay, so try also to handle it for any patient you are treating him. What is the treatment of acute diarrhea? Number one is and the most important is the ORS, oral rehydration solution. Okay. Of course, dietary handling is important. Sometimes you need to add zinc. If the patient has infective diarrhea, we may need to add antimicrobial and other. I will put beside that, the most important is the prevention. Now, in medicine, we are not satisfied by waiting for the patient to be sick and then we are treating him. We are trying to prevent the disease. Anyone can tell me how can we prevent diarrhea or gastroenteritis? Can you hear me?
Yes,
Yes,
we
you
can,
can.
doctor.
How can we prevent diarrhea?
Antibiotic.
How to prevent, sorry, how to prevent diarrhea?
Always wash their hands.
Oh,
Yeah, which is the
Hygiene.
hygiene is very important. Sometimes the mother doesn't know how to do hygiene for the bottle of her baby. What about the feeding issue? So washing hand, even Islam, he insists us to wash hand before meal and after meal, before wudu, after wudu, when we awake from sleep, when we. So it is very important hygiene, especially the hand and the food hygiene. But there is another way to prevent gastroenteritis, which is the vaccine. Anyone knows what is the vaccination for AGE? There is an important vaccine which is compulsory in the developed country, but many countries still try to retrieve it because it is a bit costly. Vaccine known as rotaviral vaccine. Rotaviral vaccine, which is very important. It will be given from the age of 6 weeks to 6 months only. It is 2 doses with oral one. It is oral vaccine. You are giving week rotavirus to the child to give him immunity. It is in 2 doses with 4 weeks apart. It is very important in preventing, not completely preventing it. Even if the patient got AGE, it will be very mild. He doesn't need admission. So they are speaking about the severity also. So it is very important to consider this extra vaccination or additional vaccines, which is very important. Rotavirus, of course, we have trying now to have vaccination against typhoid fever, vaccination against cholera, yellow fever, if you are traveling to another country with this disease. So still, medicine now are working in the prevention and the treatment, not only treatment, okay? So you can see that the treatment, we have 3 plans now, plan A, plan B, plan C, depending on the severity of dehydration and clinical examination. So for mild and moderate and severe. So now our quick assessment will diarrhea and its severity and the complication, and then we are going to ask ourselves, does the patient need any resuscitation? Here resuscitation mainly will be for the IV fluid. So if it is mild, we are going for plan B, which can be treated at home. Extra fluid until diarrhea stop, and to continue feeding, especially the breastfeeding, and advise when to come back to the hospital. If he became more sicker or he developed fever or there is blood in the school or any concern of the family. But take care here, because it is very important. Sometimes we have, what is this? Our responsibility is to protect the babies. If I feel that there is social issue, like if one, like Orang Asli came, and we are afraid if we assure the family they cannot understand, sometimes we may need to lower the threshold for admission. Otherwise, if he go home and deteriorated, he may die. Okay, so sometimes put the social situation in your background. What is the home available? Of course, the top is the ORS. Okay, but please remember that ORS is a very untesty. That's why you just try to ask the family to make it slightly cold, not in the room temperature, because at room temperature, it may be sometimes nauseating also. And try to give it as a sips or a small cup, small cup. Don't ask the child to drink all the bottle. He is thirsty and he may accept to drink it, but usually he will vomit it with some extra intestinal juice. This is the composition of the acute of the electrolyte inside the diarrhea. How much sodium, especially in children, potassium chloride, you will find in the children the sodium about 101, potassium is 27, chloride 92, bicarbonate is 32. For the cholera, for the non-cholera, you will find it is less, about sodium is less about than 50%, potassium nearly the same, but chloride also is low. So sodium chloride here are more loss, also the bicarbonate. That's why the ORS, okay, you see the composition now of the WHO before, and now they are trying to change the concentration according to the analysis of the electrolyte in the all types of diarrhea. Is it clear? So now if you asked you ORS, you will say that yes, the sodium is 75, before it was 90, the potassium is 20, which is the same, the chloride is 65, which is less than before, and also the bicarb is 30. The glucose also decreased. So we are trying to adjust. That's to know that the medicine is dynamic one, it is not static. So please, don't come and read in the old references. You must be updated. If you have the latest, if you have to read any book, you must go for the latest edition, not the oldest one. It is the pathophysiology of the diarrhea. Okay, I think you just came from the basic medical science. Don't throw the book, don't hate it. It is very important for your clinical life. Put it and try to make it a reference. It is very important what is happening between the intestine and the cells and the cyclic AMP and the ATP and the electrolytes. All this can give you the end result of the severity of the dehydration. Okay, and here is the effect on different organs are very important. And the third one, what will happen in the intestine itself with its microvilli. So please try to be very meticulous to understand the pathophysiology. As we speak before, secretory diarrhea will still secreting the, in spite of fasting, the other one is not. Okay, here is the inflammatory diarrhea, here is the secretory diarrhea, here is the osmotic diarrhea. Here is the motility one. Am I clear? We can have inflammatory issue, we can have osmotic, we have secretory, we have motility disorders. Then we can come to the management. Plan A, we said we can discharge home and ask for extra fluid and continue feeding. Plan B, we need to treat with ORS. How much? We are giving from 50 to 75 ml per kilo per motion. Okay. So it will be like that, calculated roughly for age. And reassess after 4 hours and classify the child dehydration. If still, you can continue the same plan or explain 3 rules of the treatment, give extra fluid, continue feeding, and when to come. This is a very important. Because if the patient has AGE and he is completely refusal of oral intake, he will admit just to give this ORS, but it is not no ORS, it is IV fluids. How to prepare the ORS, you must advise the family, especially if not educated, how to prepare it. When to give IV fluid, if it is the case is severe, a child started to be disturbed consciousness, rapid stool loss, frequent severe vomiting, either he is lost from upper or lower intestinal, with drinking poorly, if the abdomen starts to be distended, which you cannot tolerate, and the glucose malabsorption. At that situation, we need to admit the patient and treat as soon as possible. Intravenous fluid, sometimes you need to give bolus, okay, of normal saline or ringal lactate, now preferring a normal saline. Okay, and reassess every after the bolus and stop bolus if perfusion is good, and then you are calculating the fluid requirement, which is the fluid deficient plus the maintenance. Okay, remember that we have our maintenance and we have the deficit, and this is the way how we can calculate. Fluid deficient is the percentages of dehydration by the body weight. The maintenance, you must know that before 6 months, it is 150 ml per kilo. From 6 months to 1 year, it is 120. More than 1 year, the first 10 kilo is 100. Then the second 10 kilo is 50 per kilo. And then after that, it is 20 per kilo. Okay, 20 ml per kilo. So you must calculate what is the total amount the child needs. Of course, if there is a cause like bacterial infection or like that, you must treat it. Can you read that one, please? It is very important. In spite if it is self-limited, it is also life-threatening. Most of the cases are viral. Fluid replacement, either ORS or IV, is life-threatening. Breastfeeding should be continued unless the severe vomiting. Antibiotic and antiemetic, it is not used as a routine, please. Assalamu alaikum.
Waalaikumsalam, doctor.
Now it's your role to speak. Do you need to ask any questions?
Doctor, I have a question.
Yes.
Regarding the rotor vaccine, do we have it in Malaysia, or and if we do, how
Yes.
do parents ask for it?
Yeah, this is a good question. Thank you for that. I'm trying to work the video. It is not working. Still, the presentation is going. New. Okay, let us answer your important question, really. It is very important. Rotavirus, can you hear me?
Yes, we can, doctor.
Rotavirus vaccine has a lot of details. Here, it is not compulsory one, but it is available in the market. We have two companies trying to compete for that because it is really on most of the countries, it is obligatory now. It will be given from the age of 6 weeks until 6 months. It is oral. You just one sponsule, you will put it to the baby on his mouth and repeat it after 4 weeks. Okay, it is very effective in prevention of diarrhea and even prevent the severity of the diarrhea. Okay, it is contraindicated after 6 weeks because they said after 6 weeks it can precipitate intersusception. So after 6 weeks, usually the child is big enough, he can tolerate the viral infection. This will give you the importance of the thing that we are not only doctors, we are not prescribing the doctor. We must have a good work with the patient to advise them. We have this vaccine which can benefit the child. We have this new research about blah, 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 blah. So you must be able to be like a sociable person who can give benefit for the others. Okay. We have also now extra vaccine like pneumococcal vaccine, which prevent pneumococcal pneumonia and its complication and meningitis. We have a lot of extra vaccine. We have hepatitis A vaccine. We have varicella vaccine. All these are optional in our country because it is very costly, but some people still can offer.
Understood, doctor. Thank you.
You are welcome. Any other questions?
Doctor, I have a question.
Yes.
For the treatment, you said that we need to give antimicrobial. So is it we give it immediate we give it immediately, or we wait for the investigation result?
The investigation result, of course, blood result will come to you very soon. If it goes with bacterial, you may need to give antibiotic. Okay.
Okay, thank you, doctor.
Yes, but now there is a lot of discussion of the helping of of adding extra microbiome and like that to help the improving the diarrhea. There is a lot of studies which is also, some of them are evidence-based, but to use it in the wide range is still unable because it is a bit expensive also.
Okay, understood.
Okay. Any more?
Doctor, other than the blood test and microscopic examination, can we like differentiate between the bacterial and viral diarrhea clinically?
Clinically, yes. Starting by the age, it will guide you. If a small infant, usually it is a viral. Number two, evidenced by the contact. If he is in contact, like if some family came to you and they tell my child has vomit and the diarrhea, and when you got the history, you will tell you, yes, all of us really, or 3 members of the family got the same at the same day. So you must ask, what about your nutrition? Did you eat in new restaurant like that? It may be food poisoning. So as I told you, history and the meticulous history will help you very a lot. About 75% of the truth you can get it through the history, and you need to confirm it by examination and then investigations. Okay, if the baby has systemic disease like dengue, if the baby has, but treatment of dehydration has no relation to the diagnosis. I mean, severe dehydration, whatever, it may be very simple rotaviral, came with severe dehydration. If you didn't treat early, the patient can deteriorate. So you must be very rapid to manage, please.
All right, thank you, doctor.
Welcome. Hoping you can understood now the issue of how to go through diagnosis, how to get history, how is our flow of examination, and we make application for that for this case of D&D, diarrhea and dehydration. And remember that your responsibility is very big to pick the most critical. I think sometimes it came to you a patient who has severe diarrhea. I remember I have one patient in the early morning. He is adolescent, but he has very severe diarrhea. And just ask a simple question: what is the color of the stool? He said to you, it is like rice water. White. He said white. So just ask him, is it looks like rice water? Yes. What did you suspect?
Cholera.
Cholera. And if you didn't pick it, it's very dangerous. That's why. Put everything in your mind. Your software must be very big one, not 1 tera. For medicine, you need 100 tera to put the knowledge, but how to process it with each patient, it is very important. They told you, yes, I have fever for 5 days and I have diarrhea, and ask him how is the fever. He said it started very mild and every day it is increasing. The first day it was 37.5, then the second day 38, the third day 8.5, the fourth day is 39, and I have some headache. So now we are going to think about typhoid fever, which is a step ladder and with some symptomatic headache. And if you, even by simple test of the pulse, which is very important, you will find his pulse is not increased. We call it relative bradycardia. Relative bradycardia. It means any one of us, if became febrile, his pulse rate must be increased. But this patient is still febrile, but the pulse rate is the same. So you must consider also typhoid fever like that. So getting deep for the history and try to build up your background. And please, any case you see with us, in the world, if you are presenting one long case or short case, try. Our university are giving you now even out of campus for all references, for all journals, for all research. One you can open up to date, you can open GMC, you can open anything. So try to start early and put in your computer like a simple file for cases of pediatric and then cases of ONG and the case of other. Because even if you are going to be specialized in one subspecialty, if you know the detail for other is very important for your future life. Okay. Thank you. And at the end, I'm telling you, just remember that the Prophet Muhammad sallallahu alaihi wasallam birthday at the time, and at the time the Muslims are weak. They cannot even defend their prophets. That's why be strong in your subspecialty, so you will be strong, inshallah, Muslim and strong Muslims at all. Thank you. Assalamu alaikum wa rahmatullah.
Thank you so
Thank you,
much.
doctor.
You're welcome.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank
Thank you, doctor.
Thank you, doctor.
Bye.
Thank you, doctor.
Assalamu alaikum wa rahmatullah.
Doctor,
Yes.
can I just want to ask, can we have the slide that you are presenting just now?
Yes, I should drop tomorrow. You have session with me? I will give you-
Tomorrow.
Tomorrow,
Okay.
yes.
I check the tomorrow. Yes, we have for
Okay.
physical examination at the.
Inshallah, I will offer you both today and tomorrow. Okay.
Thank you, doctor.
You are welcome. Assalamu alaikum.
Waalaikumsalam warahmatullahi wabarakatuh.